Hi everyone, and welcome to week 3 of the rolling teaching program for sickle cell disease. My name is Christopher Dean. I am the pediatric red cell nurse specialist here at UCLH. I'm also the lead nurse for education and training for our network. So for week 3 will cover treatment options available in sickle cell disease. And just before we begin, I would like to go over the learning objectives for this presentation. So we'd like candidates to have more of an understanding of the disease-modifying therapies available in sickle cell disease, which includes both pharmaceutical and therapeutic. So we're going to cover things like hydroxycarbamide, red cell exchanges, simple top-up transfusions, Crizanlizumab, Voxelotor, and bone marrow transplant. And we'd like to give you an idea of the eligibility criteria for these, especially for our newer treatment options such as Crizanlizumab.
So first of all, we'll talk about hydroxycarbamide. So I'm no good at chemistry. I dropped out of the A level. So that's a chemical symbol for it. Not chemical symbol, the diagram of it. So the indications for sickle cell, for hydroxycarbamide, sorry, is more than three admissions of painful crises in the past 12 months. More than one admission with painful crisis in the previous 12 months and are symptomatic in the community. More than one life-threatening complication of the disease, so things like acute chest syndrome or splenic sequestration. And other indications include secondary stroke prevention and pulmonary hypertension. But as it stands now, we're trying to get all of our patients onto hydroxycarbamide by 9 months of age, thanks to the baby hug study. Exclusions. So you can't have it if you're pregnant or not using contraception or actively trying to get pregnant. So for those patients who are on it and quite healthy on it, on a stable dose, we need to think what else we could do, whether we switch to transfusions or red cell exchanges. Breastfeeding, you can cross over into the breast milk. Active hepatitis, or like I just said, if actually tried to conceive, irrespective of gender. So even men will have to come off it if they're trying to conceive. Hydroxycarbamide is like a temporary fertility issue. So once they come off it, we tend to stop it several months before we know they're trying. Someone else is joining. Let's go. So we will advise them what to do next, but if they stop taking the hydroxycarbamide, fertility should return to normal. However, for our patients who are old enough, so of age, we will do sperm banking prior to this. So how does it work? So it's an inhibitor of ignore my pronunciation, ribonucleotide reductase. It has been used as an oral anti-proliferative drug for several decades. So we know our patients who have leukemia sometimes have hydroxycarbamide to do some leukodepletion, so reduce the white cell count. One of the main things that we like about this drug is it increases the body's production of fetal hemoglobin, and we know fetal hemoglobin can't sickle. So if we can get that up to a high enough percentage, that will deplete the S percentage and should reduce the amount of vaso-occlusions happening. However, we don't know why for sure that fetal hemoglobin is produced from this drug, but it's quite handy. And it also helps reduce the intercellular adhesion and also decreases the number of white blood cells and platelets, which are often raised in sickle cell disease, which reduces inflammation and stickiness of the cells. So this is one of the things that we have to look out for, because hydroxycarbamide is one of those titratable drugs, and we increase. So we start off from 20 mg per kilo per day in children. In adults, say round it's in there 500 milligrams, and we can increase up to 35 milligrams per kilogram per day. However, if we got to a good therapeutic level, we don't necessarily need to increase it to the 35 milligram per kilogram per day. If we go too high, it can cause some bone marrow toxicity. So when that happens, the patients could go neutropenic. They could have low platelets, They could have low reticulocytes. And if that's the case, we need to stop it and pause for a week and rethink the dose. I'll go into that in a second. So the benefits of hydroxycarbamide, which I've already sort of touched on. It can reduce mortality in the long run, reduction in acute pain and acute chest syndrome, reduction in hospital admissions and pain in the community. It helps stroke prevention, may prevent chronic organ damage, reduction in priapism if the service users have had that, and reduction in avascular necrosis. But the possible side effects, which some of the reasons why some of our patients don't want to take hydroxycarbamide or stop taking it, is GI symptoms. This is quite common. This is what I hear most of for patients who are thinking of stopping hydroxycarbamide. They're getting some abdominal discomfort, they're getting diarrhea, and they just don't like it or can tolerate it. Hyperpigmentation of the skin, so lighter patches of skin. I've seen it on people's arms before. In all honesty, I haven't seen that much of it. Olu, I don't know if you have seen hyperpigmentation in your cohort. I don't think it's too common.
I haven't seen hyperpigmentation, the darkening of the skin, but sometimes they have like a rash on their face. So sometimes it's a rash that may, particularly the older girls are very particular about that and the darkness of the skin, and that sometimes it makes them want to stop taking hydroxycarbamide. So that those, but not hyperpigmentation.
Yeah, I've only seen it once. So yeah, it can happen. Darkening of the nails is another one. Thinning of the hair. So I've had a few of my teenage female patients who refuse to take it because they notice the thinning of their hair, and fair enough. And we've got them onto another therapy. And like I said, we can cause transient bone marrow suppression, so neutropenia, thrombocytopenia, and reticulocytopenia, all leukemias. So generally what happens is when we increase the dose of hydroxycarbamide, we need to recheck their blood tests in 2 to 3 weeks after we've increased it and they've started taking that increased dose to make sure that the bone marrow is tolerating it. If we notice that they've gotten neutropenic, so neutrophils less than 1, platelets less than 80, however, I hear that's up for debate about that level of platelets. But the main one is neutropenias. We'll contact the patient to stop it for a week, and then we'll recheck their blood tests to ensure that their counts have recovered, and then we will go back to the last stable dose, and then we might try again when they get older. So moving on to transfusions now. It's very hard to find a good picture of exchanges happening. But this, as you can see there, there's the senior nurse on the side with one of the, I think they're called Optica Spectra machines, something like that. And they're going to be doing an exchange there. So we'll talk about that. So indications. So for an acute blood transfusion, we might do it for acute chest syndrome if we caught it early enough. Normally with acute chest syndrome, we might go straight to an exchange, but like I said, if it's early enough, we might try a top up. Splenic or hepatic sequestration, because we need to correct that life-threatening anemia rapidly, so we can give a transfusion. An aplastic crisis, so the bone marrow is not producing any red blood cells, so we need to correct that anemia. Stroke as well, or stroke prevention. So say in our pediatric population, for example, if they have conditional TCDs, so transcranial Dopplers, we might start them on a transfusion program. We try to get our patient on hydroxycarbamide instead nowadays because of the risk of hemochromatosis and antibody development. However, I have a couple of my patients who refuse to swap to hydroxycarbamide because they don't want to rock the boat, because they know the transfusions are working for them. So we have to balance the risks of all that and start chelation if necessary.
We have similar ones here as well that don't want to swap. They just say, well, what's the point of changing, particularly with hydroxycarbamide in the males where there's this thing about infertility. So they say, no, we're staying on transfusions.
Yeah. But those patients, they just need to be really good with their collation, and we just hope, cross all of our fingers and toes, that they don't develop antibodies. But thankfully, at the moment, my caseload are okay. It could help with multisystem organ failure, fat emboli syndrome, which, for those of you who came last week, you'll know how stupidly rare fat emboli syndrome is. Pre-emergency surgery, or even planned surgery. You know, some of our patients we get in the night before to give them IV hydration. We do a preoperative plan where we do a transfusion or exchange just before, depending on the length of time under anaesthetic and what surgery they're having. But for long term, we could do stroke prevention, so primary, secondary. Pregnancy. What have I put that for? For those on pregnancy, for those on hydroxycarbamide, if they're having a multiple pregnancy, previous issues relating to sickle cell disease and pregnancy. However, normally we get our patients onto exchanges during pregnancy. In our service, we have capacity for space for our pregnant patients. Obviously, we have a finite number, so hopefully not everyone gets pregnant all at once. Recurrent acute chest syndromes despite hydroxycarbamide, and recurrent admissions with pain despite hydroxycarbamide. So modes of action. So one of the reasons why we do it to correct anemia and the oxygen carrying ability of the blood, to effectively reduce the patient's S percentage relative to the HbA donor blood. So which one should we do? So for top-ups, it can cause hemochromatosis, as I said, over time, requiring collation. Patients may have a higher baseline hemoglobin, so may not have space to top up, because obviously we don't want to make their hemoglobin go too high, because that's a risk of more sickling happening, vaso-occlusive crisis happening. May not be able to get the S percentage down as much as we like, and it might take longer to do so. Whereas with the actual red cell exchanges, less chance of iron overload. It uses a larger volume of blood, so for a grown patient, we can use between 8 to 12 units, and this is like every 4 to 6 weeks that they have this done. Can be partial or full exchanges and can be done manually / automated. We have very few adults who have manual exchanges at the moment. However, for our pediatric populations, if they come in an emergency, then sometimes we can't use the machine because they're too small or the machine's not available. So we might have to do a manual one. And that is very time consuming. It always happens at like 2 in the morning that you have to have 2 cannulas in the patient, a very compliant young child. If you can have a play specialist, great. And it's literally aspirating out syringe by syringe the blood out of them if we can. However, as we know, it's tricky enough when it's sort of like a prophylactic regular manual exchange program, as opposed to they're unwell and the blood is so sticky, you might need to have a VASCAF. So it's a bit of a nightmare. Vascular access can be difficult. As we all know, our patients, their blood vessels are scarred, very difficult to gain access usually. So quite in our adult population with patients who are on the exchange program, if we can't do normal cannulation, we might try ultrasound cannulation. If we still can't do it through there, we might opt to have a portacath inserted. However, we have to weigh out the risks of that because of the risk of thrombi. Some of our patients have VASCAFs every time they come in. In an emergency, we tend to pop in a VASCAF and then do the exchange via the 2 lumens on that. We've recently had to get a stock in of VASCAFs for pediatric population just in case anyone needs one. However, usually because of the risks of doing the exchange of hours, sometimes the patient needs to be retrieved to intensive care settings where they can do the exchange pretty quickly and put the VASCAF in.
Can I just add, because of because of the screening program that we're doing with TCDs, usually the indication for exchange transfusions have gone down because it was mainly for stroke and maybe chest crisis. And a lot of our patients are now on hydroxycarbamide. So these complications are very rare now. So we probably, I can't remember the last time we've had to do an exchange, maybe in the middle of the night. It was probably for a child with priapism that we had then said we'll just send to UCL anyway. So if the child needed it, but by the time we got there, it was a lot better. And so he didn't need it. So thank God, thankfully, we don't really have to do these emergency exchanges anymore, particularly in the younger children, which is really hard because they're not going to keep still unless they're really unwell, and then they'll keep still. So, and for those that are on regular transfusions, like regular exchanges, I think the way we've got around it for some of them really, really bad access is actually to get them have a portacuff. And I think it's really important the way there's particular portacuffs that should be used for the older children, and they have to be flushed. There are particular needles that have to be used. So I think it would be really nice if we could have maybe some training or lecture on that side of things. You're really lucky at UCH because you can put in VAS cards in. We can't do that. We either have a port put in, which has to obviously be prearranged, or we just have to manage, or we have to send the patient out. So
yeah, okay, good to know. I'll take note of that, and maybe we can talk some more about that another time. But yeah, if they're having like a portacuff for exchanges, then they normally need to have a vortex, so they have a 2-lumen port, which is tricky enough, let alone a children's size one where it's like tiny. But yeah, the VAS cuffs we have, but normally children tend to get retrieved if we can't manage peripherally because we don't have a PICU on site. Normally we send to St. Mary's. Okay, so Crizanlizumab, which is also known as Adakveo. Like I said, this is a new sickle cell drug, first new one in 20 years. You might have seen one of our doctors on the news talking about it. So what is Crizanlizumab? It's a p-selectin inhibitor. And I'll talk about that a bit more in a minute. Have you guys rolled out yet? Started to do it? I know in pediatrics,
I think the adults are, but obviously because with pediatrics, I think it's not licensed yet. So
hopefully
yeah,
soon.
Hopefully soon, yeah. So until it's licensed, no, we haven't started anybody on it. So I think the adults, and I think the problem with the adults is they're looking for a place to give it because they feel that they're going to have lots of patients and they don't want to be doing it in hospital. So I think they're thinking about it being done at the George Moore Centre, but they need to make sure that there are enough nurses and there's an acute facility just in case anybody reacts and stuff. So that's, I don't know, you probably have lots of patients on it now, don't you, adults?
Only about 10.
Okay. Yeah.
At the moment, and I'm just about to start one of my teenagers.
Okay. How old?
17.
Okay.
Okay, so Crizanlizumab is humanized monoclonal antibody. It binds to the p-selectin, which causes the stickiness to happen. So the mode of action is blocks the interaction between endothelial cells, leukocytes, platelets, and red blood cells. In turn, this prevents vaso-occlusive crises. Hard to find a decent picture to put on this slide, but there's a tiny little p-selectin there. So the study that and research that was done to get this out and through NICE was called a SUSTAIN study, and includes patients who are on hydroxycarbamide and not. And it showed a significant 45% reduction in the median annual rate of vaso-occlusive crises with Adakveo versus placebo. One of the little graphs they sent me. So eligibility, of course, have to have a confirmed diagnosis of sickle cell disease and be aged 16 and over and had 2 or more confirmed sickle cell crises, so VOCs, in the previous 12 months. That doesn't necessarily mean they need to be in hospital for that. It could be at home. So it's pretty lax eligibility because 99.9% of our patients would have had crises at home. Be assessed by a member of the specialist team responsible for your care who can present your case to the regional multidisciplinary team for review. So for our network, we have a HCC MDT where consultants bring a patient in and we'll talk about whether they're eligible for Crizanlizumab or whether we say, have you tried Hydroxycarbamide yet? Maybe we should try that first before we move on to Crizanlizumab. But by and large, most people are accepted onto the program. These criteria and the review by the multidisciplinary team are standard within the NHS to identify patients who are most likely to benefit from treatment and to ensure fairness for patients in all of the country. So because UCLH, for example, we have a daycare dedicated to haematology, a whole building. So we have started it here. We've probably got about 10 patients on it at the moment. And so far, so good. No one's dropped out of the program, but it's too early to tell what sort of effects it's had.
You know how much it costs an infusion?
I think it works out about 10,000, 10, 11,000. It's really expensive at the moment because obviously the license is stuck with Novartis. But I'll confirm that because I'm always interested in that. But I always get told it's thousands.
Yeah, I know it's expensive, but I don't know how much.
And yeah, that must be the reason why I go to the MDT as well, just to say like, are we paying for this? Because we have to fill out a blue tech form in order to get it. So side effects, so nausea is very common, abdominal pains very common, arthralgia, back pain, pyrexia, oropharyngeal pain is common, diarrhea is common, vomiting, and pruritus. However, I haven't had anything reported to me from our cohort that are on it. So either they're suffering in silence or it's all going okay. And the way that it's given, it's an IV infusion. We do it at day 0, then we do it after 2 weeks, and then it's every 4 weeks after that. We have a window of 2 to 3 days either side of the infusion date for it still to be effective and follow the schedule. If they say they forgot and they can't come for another week, then we have to start the whole process again. I start at 0, then 2 weeks, and 4 weeks. So it is commitment. And at the moment, everyone's refining the pathways that they're using because it's new and we've rolled it out fairly quickly. And different hospitals have different ways of doing things, obviously.
So for those that are regularly non-compliant, you're having to give more because basically they then have to come back in 2 weeks. So is there any decision to say, look, you're non-compliant, we can't give you this medication anymore?
So before we even start the program, we have to say to our patients that you need to show us that you can come to clinic, you can comply with treatment, and before we'd even start doing it. And I think we haven't finessed that bit yet. Say if someone started and they're not coming. But usually if it's like the Red Cell Exchange program, if they DNA twice, then we tend to have to take them off of it. But we haven't come across that yet. So when we do, I'll ask Perla actually, because she's in charge of it.
And my other question is, do you have to fit them before they have Crizanlizumab, like chemo? Like we have to review everybody just before they have chemo. Whereas transfusions, the nurses do their obs and just make sure they're fine. I don't know whether it's the same with Crizanlizumab, where they have to do a whole examination, like pre-Crizanlizumab examination to kind of before they're given the drug, or they just do obs and then they can have the drug.
We don't see them in clinic before. We do initially, and they stay behind after the infusion, and one of us tends to go over and check in. But we have therapy plans or SACS plans, so we follow sort of like the chemo critical care tests. But generally, once they've started the program, we don't need to see them. But we see them more regularly than if they come to normal clinic, just as a see how you go. So Voxelotor, So Voxelotor is one of the other drugs, works slightly different. So it's a hemoglobin S or HbS polymerization inhibitor that binds to HbS with a 1-to-1 stoichiometry and exhibits preferential partitioning to red blood cells. And it increases the efficiency of hemoglobin for oxygen. So Voxelotor demonstrates dose-dependent inhibition of HbS polymerization. Bit of a mouthful. So Voxelotor inhibits red blood cell sickling and improves red blood cell deformability. So theoretically, if they hold onto the oxygen, the red blood cell maintains a good shape and it's able to get through the blood vessels. Again, difficult to find a picture of the actual process happening, but as you can see here, red blood cells, the little squiggly bits of the hemoglobin, blue bits of the oxygen molecules, and the yellow Oxbryta is the Voxelotor. Oxbryta, I think, is the brand name. So side effects include fever, low energy, skin rash, headaches, nausea, abdominal pain. But again, I haven't had any contact from patients who say they are having any side effects with it. We've adult patients, quite a fair few of them are on it. And then pediatrics, I've already got about 5 of my patients have taken Voxelotor. Because it was part of a study, then we had a 53 spaces or access to it. And they're continuing to take it, and I rarely see them nowadays, but I use it alongside Crizanlizumab. Not Crizanlizumab, sorry, Hydroxycarbamide. So just last one to briefly touch on is bone marrow transplantation. So sure everyone knows what bone marrow transplant involves, so we have to find a donor. We are very active in how we approach this now. In every annual review, we'll check in if they've got any full siblings, because at the moment, the majority of the transplants are done only with a full HLA matched sibling, so both the same parents. That's in the adult population. In pediatrics, we've been doing it for longer, so we do full HLA sibling matches, but we can also do haplo. So a parent is a donor. However, we don't do transplants in this trust. It's very few limited who can. Actually, we do adolescent transplants, but we don't do children's transplants at UCLH. So we tend to refer to St. Mary's because they're excellent red cell center as well. So yeah, in our clinics, we'll offer the sibling testing. We'll talk about it. Doesn't necessarily mean that they're going to be eligible for it to go forward, but at least we have the samples on record and we know that if they want to progress with that and we suggest it, then we can do further testing. We only do type 1 to start with, because then if type 1's matched, we'll move on to type 2. But if you're not matched on type 1, it's pointless doing the type 2 more in-depth testing. So once we have the donor, we prepare all the cells, we'll bring the recipient in, we'll start doing the conditioning treatment, so the chemotherapy and plus or minus radiotherapy, so TBI, in order to wipe out their bone marrow effectively, ready to receive the donor cells. And then after that, we will support them with various different drugs in order to ensure that they start engrafting. And then they can be discharged after they've engrafted and everything's okay. So in pediatrics, normally we could expect patients to be in for 4 to 6 weeks, all being well. We had one, I remember when I was a ward nurse, there was one young lady I did a transplant for with Sickle. And she had a bit of a rough ride of it, bless her, but she's made it through and she's fine and she's cured. But for adults, we've actually done one recently where it's just been an outpatient transplant, just going into our daycare and staying in our hospital hotel, which I find remarkable that that's possible. And she's doing really well. So as I said, it's commissioned for adults in England since 2019. But before that, we can do it in pediatrics. It's the only curative therapy currently available in the NHS. Chemotherapy destroyed patient bone marrow donor stem cells from new bone marrow, making non-sickle red blood cells, and it's about 4 to 6 weeks in hospital. Has to be best results are a fully matched sibling donor, as we know. Only about 20% of patients will have a HLA matched sibling. It's not funded in adults for any other kind of donor due to the concerns about using an MUD, haploidentical, and the risks of graft versus host. However, we are opening up a trial later this year for haplo transplants in adults. Hopefully by the end of the year, we're opening that, and we're starting to put out the feelers about who might be interested.
Do you know from your experience, from my experience, the haplos don't do as well as the sibling match, and some of them basically have GVHD for a long time. So could we tend generally trying to follow them up? So I'm not for haplos particularly because they generally have lots of problems. The other thing is that I question whether you look for related matches and whether actually, because I know the Anthony Nolan bone marrow trust and also the ACLT, they have a registry whereby you can look for non-related donors, and I think even the non-related donors probably do, if they're a very good match, probably do better than the haplos. But that's just my opinion. I don't have any data or anything about it.
Yeah, I mean, that makes sense to me. You know, haplo, I've not seen many success or much success, or sort of success at the start and then the graft fails later down the line. And we have, I think there are case studies of doing matched unrelated donors through registries, but I'm not sure of the outcomes of those ones. The full sibling is the best from my knowledge, but who knows what this trial might bring up. I mean, it's a lot of pressure as well, isn't it? If it's haploidentical, they've got it from one of their parents, and if that fails,
exactly,
it's horrible. It's eligibility, clinically significant neurological vascular event or deficit lasting greater than 24 hours and confirmed radiologically. History of ACS despite hydroxycarbamide or transfusion therapy. History of severe painful crises or other acute complications per year despite the institution of supportive measures. Administration of regular transfusion therapy. Patients assessed as requiring transfusion, but with red cell allo antibodies, very rare blood type, making it very difficult to transfuse. Patients requiring hydroxycarbamide transfusion for treatment of sickle cell disease complications who cannot tolerate either therapy due to significant adverse reactions. Established end organ damage including but not limited to progressive sickle neurovasculopathy and hepatopathy. So yeah, even when the referrals are made, it's still going to go to the national MD2 to decide that's the best route. And there are more, in the meetings I've attended, I've seen more and more referrals, and it's still a hot topic amongst hematologists from my standpoint, whether we've really exhausted everything else before we do such a risk, because not everyone makes it through the transplant process. It's got better, but obviously with the conditioning and chemotherapy and risk of graft versus host, they're open to all sorts of infections, which I'll talk about now. So side effects.
The other thing is that if my thing about the transplants is that if you already got end organ damage, and that therefore you probably have loads more complications during the transplant, number one. Number two, the transplant, even if you're successful, is not going to reverse the end organ damage. Yep. So therefore with children, we're not going to wait for them to have end organ damage. And that's why I personally feel that they should be referred if they have a matched sibling donor. And yes, you've exhausted all the other things, but not wait for them to be pretty bad before they're sent off. Because there was a child that I remember who, and I don't even think she was that bad in terms of her complications, but she had seizures and stuff like that. So the transplant is not really easy. It's not easy at all.
Yeah, it's a hard process. It's a lot for the families to weigh up and decide whether they want to proceed. So short-term side effects is infection, nausea and vomiting, mucositis is a big one, fatigue, diarrhea, low blood count. So obviously with the chemotherapy and myeloablative treatment, we're going to cause profound neutropenia, so absolute zero, flat neutropenia. And you're going to need blood product support, platelets, red blood cells, and it can cause acute GVHD, so graft versus host disease. For those of you who aren't aware of what that is, it's when the graft is recognizing and the donor cells are recognizing your body as foreign, so it starts attacking itself. So this can happen anywhere. So I've seen pretty severe gut GVHD, skin and GVHD, and even though you can deem a transplant successful, and sickle is gone or the leukemia is gone, for example, graft versus host can still happen a long time after transplant, and that could effectively prove fatal as well. I've seen that a couple of times, which is really horrible when you can say to someone you don't have leukemia anymore, but this is what's the issue. So long-term infertility, but we do cryopreservation if they're of age. Chronic GVHD, as I said, thyroid problems, lung or bone problems. It can cause cancer. Usually it's called a secondary cancer, but if we're doing it for sickle, it's going to be a primary cancer as a result of the chemotherapy treatment and the drugs that are used. Unfortunately, in sort of malignancy type transplants, I've seen someone having leukemia and then it's developed into a osteosarcoma afterwards, like several years afterwards. So it's really sad and really unfortunate when that happens. It's horrible. And that is it. The brief talk is over. Does anyone else have any questions they want to ask?
I have a question. And it's a brilliant talk every time. I just feel so many people should listen to this and not many people are on it. So it's really, it kind of frustrates me, but a lovely presentation. My question is regarding the preservation in terms of what ages do you do them? Because I know that it's done at UCH for males and females.
Yeah, so generally speaking, if boys are of age, we will, or start of puberty, we will take them down. It's difficult. We take them down to this fertility suite where they can produce a specimen. If they feel uncomfortable down there, then we will do it in the side room and we sort of leave them to it. And then they'll let us know when they're done. Or we could do the TESI, so the extraction from
what
the
age?
testicles itself.
What age?
So I'm not quite sure on the policy, but the youngest I've seen it is about 9, 10. Let me have a look for you. I'll find the policy. I'll have a read of it.
Thank you. I'm just curious. And what about females?
So females, we could do the egg harvesting, and we can also do, there's the other one where they take trying to figure the proper word, like take a sample, take a slice of it and freeze it.
Of the ovaries, yeah.
Yeah, I'm trying to figure.
I don't know what ages.
Okay, I'll look that up for you, Ollie, and I'll send that.
Please. I'm interested because when I'm speaking to parents about, because this is one of the questions they're always asking about infertility. And when I'm speaking to parents, it'll be really good at least to have a better idea of what happens when we're talking about bone marrow transplant.
Yeah, of course. I'll find, as soon as we finish, I'll find it and I'll email it over.
Thank you.
It'll be on there, on our internet somewhere. Any other questions before we end? No. Okay, guys. Well, I hope you all survived the heat. I'm going to try my tap now to see if I've got water.
Good luck.
Thank you. But enjoy the rest of your days, and I'll see you soon.